Welcome to AETCM, the emergency medicine channel. A 77-year-old male presented to ER with complaints of pain and numbness over the right upper limb since 3 to 4 hours. It was started at the morning at 6 am. He presented to our ER at 10:30 am. On initial 10-second assessment, airway was patent, no pooling of secretions. Respiratory rate was 18 per minute, saturation 100% on room air, air entry bilaterally equal. Coming to circulation, BP was 100/70 millimeters of mercury. Pulse rate was 110 per minute, regular with normal volume over the left upper limb. On right upper limb, the radial, ulnar and brachial pulses were not palpable. Axillary pulse was there. Coming to disability, GCS was 15/15, pupils equally and reacting to light. Coming to exposure, patient was afebrile, GRBS was 120 milligram per deciliter. Okay. Coming to history, 77-year-old male who is a known case of CAD, status post PTCA in 2013, SCAR VT, status post pacemaker with defibrillator in 2013, severe LV dysfunction, CKD with a baseline creatinine of maximum 2.9. He had complaints of acute onset of pain and numbness over the right upper limb since 3 to 4 hours. No history of weakness of the upper limb, associated lower limb symptoms, slurring of speech, headache, vomiting, and not associated with any chest pain, palpitations, or any history of trauma was not there. On examination, patient was conscious oriented. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema.
Local examination, you can...
Right upper limb on inspection, hand was pale, no scar marks or wounds seen. Palpation, right upper limb was cold, right axillary pulse was palpable. Brachial, radial, ulnar pulses were not palpable. A tardy waveform on fingers noted with SpO2 reading of 89% on the right upper limb. No limb tenderness, no pain on passive movements.
Whenever you're doing, just compare with the opposite side. Just let me know if it is a diffuse disease or it's an isolated one. So right side the patient was complaining,
only the complaints.
The left side what was the finding? So it will be giving you an idea.
Left upper limb was normal color and normal temperature. Left side all pulses were palpable, and we took the BP and saturation over the left upper limb.
Okay.
There was no limb tenderness bilaterally, no pain on passive movements bilaterally. There is paresthesia. Patient was complaining of paresthesia, but there is no motor weakness of the right upper limb. ECG, initially it was showing a 110 rate of occasional VT. And then after we took a repeat ECG, it's showing a pacemaker rhythm of 80.
How you said it is VT?
Because with magnet and without magnet, it was having a wide complex tachycardia, and no pacemaker rhythm was seen in the first ECGs.
Whether it was a pacemaker or the patient had an AICD implanted?
From the history, they have written as pacemaker with defibrillator. They have.
So then what is it?
ACD.
It is mostly like an automated implanted cardiac defibrillator. See, whenever you are placing an AACD, it will be coming as a combination. So for VT, we don't want a pacemaker. When he had a VT, we don't want a pacemaker. So the history that you need to ask is that whether the patient VT, if they are coming in, whether any AACD shock he was receiving, something like if the patient had recurrent VT, if some shock feeling was there for it, that is a question that you can ask. So probably this patient is on an AACD implant with a pacemaker, with a dual chamber or whatever be the type. There are different types of pacemaker. It's not to the scope of discussion. So some implantable cardiac defibrillator along with a pacemaker is available for this patient. So ECG you said regarding probably he had intermittent short runs of VT. What could be the reasons why the captures was not happening properly or the pacemaker was not functioning properly? Ideally, when you place an AACD, you should not have this runs of VT. So what could be the reasons why you are seeing this?
Failure of that.
Failure of the
implant.
Okay, AACD can be pacemaker or the AACD whichever it has been placed can be failed then.
The set rhythm may be.
No, you have to clarity. Set rhythm. Why you want to set a rhythm here? You are not doing it for a complete heart block. You have done it for a VT probably. That we need to explore it. So VT, what will happen whenever the patient have VT, the machine will automatically detect and it defibrillate. That's the basic idea behind an AACD. So the machine somewhere it is not functioning, maybe the lead misplacement, or the most important thing, it can be an acidosis, hyperkalemia. These situations is the time when the machine can go fail because of the electrical conduction and the rhythm disturbances in the conduction system. So sometimes it will not be able to detect those rhythm because of acidosis and hyperkalemia. So that could be the other possibility. So we'll just leave alone that, and so probably we are dealing with a patient, probably an embolic stroke, embolic phenomenon, sorry, not a embolic stroke, embolic phenomenon arising from the heart, and the patient has got an acute upper limb ischemia. When we discuss regarding acute limb ischemias, why we are not seeing upper limb ischemias very common, we are seeing more of lower limb ischemias. What is the anatomical differences?
Upper limb, the arteries will mainly wide board, so the thrombus and embolus should the.
What is the difference between a thrombus and an emboli? We are using it. Terminology is very differently. Thrombus is something different. Emboli is something very different. So emboli can be a gas, it can be a solid, or it can be any liquid also. So that is the difference. But thrombus is always a blood clot. So that is a basic difference that you need to differentiate. Whenever you are saying embolus, embolus is that basically it can be a pulmonary embolism, it can be a blood that is causing, or it can be a gas or an amniotic fluid embolism. So any of these things together you can call it as an embolus. But whenever you call it thrombus or a thrombi, it is a blood clot. So that is a basic difference that you need to understand. So when you look at the caliber of the blood vessels comparing to the lower limb and upper limb, you don't have larger blood vessels much in the upper limb. So you will have smaller blood vessels mostly. Whenever you see the problems that is happening in the upper limb, mostly it can happen in the subclavian level or maybe in the axillary and maximum to the brachial level, and that is very rare. But we take into the lower limb, starting from the lower limb, from the femoral artery itself, you can start having diffuse disease. So that is a basic difference that you need to understand. And upper limb, most common reason to have this is two things that you need to, most commonly what we need to think in an emergency, but acute onset is most commonly an embolism. Acute onset. So here the patient has got some history of arrhythmia, something is there. So we can confirm that probably an emboli has gone and start obstructing one of the, somewhere between, as per your history examination finding, somewhere between the after the axilla and in the brachial blood vessel, it is causing the obstruction. So that is what we have come to the conclusion. Now in the ED, what could be the, we have said regarding the upper limb, the cardioembolic phenomena. What are the other causes that you need to anticipate? 1, 2, 3 for the same patient. Rare, but just I am asking you.
Vasculitis.
Okay. Vasculitis, it will be unilateral or bilateral?
Usually bilateral.
Okay.
And associated symptoms.
But it can there can be some Raynaud's phenomena in the background history. Cold, when they are going to the cold, the Raynaud phenomena, all those the classical they might give you. But it's a male or a female patient?
Male patient.
Male patient. At the age of 73, are you expecting a vasculitis? Rarely. Okay, then.
Stroke. Acute CVA.
Acute CVA, why it should cause a pulse, absence of pulse? It can cause CVA, but how does a CVA happens to this patient? How does a CVA can happen to this patient? And that resulting in the loss of this pulse. What do you mean by paradoxical embolization? When you have a persistent foramen ovale, you have got a pulmonary embolism or a DVT, you have got a DVT and that is getting shredded into the brain. But you don't think about paradoxical embolization, just think about normal embolization phenomena where from the same source, one emboli can go to the brain and one emboli can go to the limb also. Can you cardioembolic again? But rarely we can have aortic dissection. Aortic dissection. So you have got an aortic dissection. Aortic dissection can sometimes extend into the blood vessels, into the upper limb blood vessels. To one side, when you are checking to the one side of the limb, there is no palpable pulse. And blood pressure, there will be variation between upper limb and upper limb, both the sides, there will be variation. So aortic dissection is one thing, and the same thing, there can be an emboli can shred to the brain also. An emboli can go to the upper limb also, and the dissection also can extend into the blood vessels. It can extend to the subclavian, causing a distal vascularity problem, or an emboli also can get transmitted, or from here also it can go to the brain. So that is very rare, but we had patients with that. So aortic dissection is one thing that you need to keep in your mind as a differential diagnosis. Very rare, but sometimes the same things can happen. Then what else can be the possibilities?
Normal atherosclerotic process can...
Normal atherosclerotic process, why it is not happening in the lower limb? Why it has happened to the upper limb? Whenever we say peripheral vascular occlusive disease, it is mostly happening in the lower limb. So most common reasons is these two things that you need to keep in your mind, and mostly and cardioembolic is what is happening in the upper limb. So that is the basic pathophysiology what has happened to this patient. Now let's see what can be done. You are in the ED, this patient has come with an acute upper limb ischemia. So what is your plan of management? You have to give analgesics. So mostly this patient require a higher amount of analgesics.
Yes.
They will not settle with your paracetamol and all. Maybe you need opioid analgesics.
Then the imaging should be done.
So whenever you have a suspicion like this, you can give one shot of heparin straight away. That's okay. We can give one shot of heparin. Unfractionated heparin, you can give 5,000 unit IVs, subcutaneous or IV, whatever be the mechanism. You give a heparin shot initially. Then followed by, you have to decide what imaging is required. You have gold standard imaging, you have invasive, non-invasive. So which is the best investigation that you need to do in this patient?
CT angiogram is the investigation of choice. But initially we can do a UC Doppler.
That is more than enough. You can do a bedside investigation of an arterial Doppler. So that will be the initial, for irrespective of whatever you are planning to do, you have to do an arterial Doppler for any PVOD patients, acute limb ischemia that is coming to the emergency room. So what are the features to say in your Doppler? What are the things that you want to look into the Doppler?
See the color flow through the artery and the color pickup.
So what is the type of flow, whether it's a biphasic or a monophasic flow? These are the flows you will be able to identify by doing the Doppler. When it's a usually good biphasic flow, that means there is no compromise. But whenever you see a monophasic flow, there is some compromise in that area. So these are the differences that you can make. And next important thing is confirmatory diagnosis, what needed to be done, whether you wanted to do an intra-arterial thrombolysis, or you want to do an embolectomy, or you want to do a surgical removal of the thrombus. So that is the questions that comes in our mind. For that reason, you definitely need a CT or a MR angio. So CT or MR angio is mandatorily required. So depending upon the renal parameters, you decide which one is needed, whether you go ahead and want to a CT angio and a peripheral angio. So CT or a MR angiogram. So what was done for him, the patient?
Doppler. Doppler was done, and it was showing a thrombus in the brachial artery and the low flow through the
thrombus or emboli?
Thrombus, echogenic thrombus in brachial artery in mid-arm. Poor flow seen in radial and ulnar artery at the wrist level.
Okay.
So we gave heparin, 5,000 initial subcutaneous stats, and we gave a call for vascular surgery. They actually advised for CT angiogram, and but the patient was not willing, so they admitted, and it was Rutherford class 2A like. So they were planning for embolectomy, thrombectomy, but the patient was not willing, so they discharged with oral anticoagulation, apixaban 2.5.
Okay. So you have to tell me, you said regarding something regarding Rutherford. So Rutherford 1, 2A, 2B and 3. What are the differences? And management depends upon basically this on this classification. You can go ahead and tell.
Rutherford 1 is a viable limb, 2A and 2B is threatened limb, 3 is...
What is 2A and 2B difference?
2A and 2B is actually that is the pain will be pain will be moderate and severe in 2A and 2B. Then capillary refill time will be both delayed in bilateral. Motor deficits will be, there will be no motor deficits in 2A, partial deficits in 2B. Sensory deficits will be not will be there. And then arterial Doppler both will be inaudible. Venous Doppler both will be audible. This is main difference. So the management is for 1 it is urgent, we should evaluate for the cause. 2A urgent revascularization should be done, and 2B it is emergency revascularization, and 3 is it is
already the limb has gone.
Non-viable
so all
limb.
the 6 P's. What are the 6 P's?
Pallor, pulselessness, paralysis, pain, um, uh,
Something with cold.
paresthesia,
Paresthesia. Pallor.
pallor,
Tell me next.
pallor, pulselessness, paralysis, paresthesia.
One more is there. Huh? That is pallor, no?
Pain.
Pale and pallor is the same, no?
Pain.
Pain, okay. Okay, fine. So these are the 6 P's that you need to remember. Okay, fine. So this patient was on 2A.
2A.
So as an emergency room, our aim is to differentiate this, and you need to have an immediate intervention. So what else you need to do, and what are the treatment options for this group of patients? What are the options that is available? Do you want to do a vasculitis workup for this patient? I don't want to do a vasculitis workup. When you want to do a vasculitis workup?
When it is young females.
Young males or young females, most commonly in females, and they have come with history of Raynaud's phenomena and all those things. Definitely, you need to have a vasculitis workup. So what are the? It's an arterial thrombi formation. So what are the workup that you need to send?
ECG can be done to look for AF or any arrhythmias. Echo should be done to look for any LV or LA clots, and then DVT. If there is pain.
Why you wanted to do DVT? It is an arterial thrombi. So what are the investigations? What else you wanted to do?
Then blood.
Autoimmune workup. What all things you wanted to say? ANA. What is the most common one causing this? APLS syndrome. APLS syndrome you need to send. You need to very rarely protein C, protein S deficiency. All those things and male patient who is smoking, homocysteine levels. So these are the things that when you are having a patient with young patient with you want to look like young stroke, what we all evaluate. Similarly, you have to evaluate in a patient when they are presenting with this. So what are the treatment options available? You have embolectomy. You have intervention radiology, you can do an embolectomy. Then 2 is a surgical removal of the thrombus. Then what else? Thrombolysis, intraarterial. Again, that's an interventional procedure. You can go there, intervention, and give an TPA. TPA you can give this. And then what are any role for prostaglandin infusion?
In Raynaud's phenomenon, we can give.
Previously and all, we used to give this
vasospasm
and all. We used to give prostaglandin infusion specifically for this PVOD patient who is coming with critical limb ischemia. So only problem, what can it cause? Prostaglandin infusion.
Side effects will be nausea, hypotension.
Nausea, hypotension. That is a main problem. So hypotension, then.
If there is pulmonary artery hypertension,
it can also very rarely it can lead on to an ACS also because of the hypotension. Because it's a vasodilation. So sometimes it can, because of the hypotension due to the poor tissue perfusion to the subendocardial area, you can have very rare complication. But we had seen patients who was on prostaglandin infusion developing an ACS. Okay. So that is but these days we are not very commonly using, but there's a prostaglandin infusion can be tried. It's not to be tried, it can be tried. So that's it. And again, when you are having an embolic phenomenon like this, definitely you need to start with your oral anticoagulant. So whichever you prefer, you wanted to put him on warfarin, you want to put him on macetronome, you want to put the novel anticoagulants that is available, apixaban, rivaroxaban, any of these things you can give. What are the problems with this? These are not having much reversal agents. It's not yet available in India right now. Andexant alpha and all 10A inhibitors is getting launched on November. So that is a good news that we have. So November we are going to get that in India. So once we are getting, we can basically for life-threatening bleeds like intracranial hemorrhage on our novel anticoagulants we can give. So that is the thing regarding. You have anything else to be added on? You can just tell.
So classification we told that.
So our concern, acute limb ischemia coming to the ear. Upper limb is not very common. Lower limb is what is very common. So claudication pain. You have to differentiate between acute limb ischemia and a chronic limb ischemia. That is very important. So when you will say it's an acute limb ischemia? When the symptom onset is within?
Less than 2 weeks.
Less than 2 weeks onset. So less than 2 weeks onset, somebody is coming to the ear. Within 2 weeks onset, he is having some problem. You can think in terms of an acute limb ischemia. And basically the investigation, whatever be the reason, the investigation, a Doppler is what is the basic investigation that what we need to do. And next, CT angio or peripheral angio with MR or CT, whichever you are able to do, fine. But don't forget most common reasons, cardioembolic phenomenon. And when you're thinking out of lower limb, the totally our workup will be different. When you have a patient with popliteal artery aneurysm and all, it's a very critical area. So aneurysm can produce a thrombus and suddenly the whole limb can, the patient can have lower limb weakness. So these lower limb areas and all, there are a lot of theories like giving antiplatelets. You can help the patient in, but whenever you are seeing it's an acute limb ischemia, there is no point in waiting. You need to do either a thrombectomy or a bypass grafting, whatever way it is, so that to preserve the limb. But chronic, what is the advantage? There will be a lot of collaterals. Acute limb ischemia, you don't have any collaterals. So chronic, they will have collateral. So that is the reason why they are moving forward without much issues. So, and regarding when you suspect, you give one dose of heparin straight away, and then you decide what, even the patient is taken for surgery or any intervention, one dose of heparin is not going to get affected. So that you can practice unless and until you don't have any life-threatening bleeding or any other contraindication, you can definitely start your heparin one dose. Okay, fine. Anything else? Nothing, right? Thank you.